This is Audible Bleeding, the vascular surgery podcast. We're here to help you keep your finger on the pulse.
Welcome back to Audible Bleeding. I'm Jacob Schwartzman. I'm here today with Editor-in-Chief of the Journal of Vascular Surgery, Dr. Peter Gloviczki, to discuss the Editor's Choice articles for the month of March. Welcome back to the podcast, Dr. Gloviczki.
Hi, Jacob. It's a pleasure to be here, and I'm looking forward to discuss these great papers that we published in the March issue of the Journal of Vascular Surgery.
Excellent. So this week we actually have 5 articles to discuss as opposed to the usual 4. The first, which is also the Editor's Choice article, is the new reporting standards document from the Society of Vascular Surgery and the Society of Thoracic Surgeons for Type B aortic dissections by Dr. Lombardi and colleagues. This article aims to improve on the traditional DeBakey and Stanford classification systems to provide additional granularity on the proximal and distal extents of dissection for ease of communication and reporting. In the new system, type A dissections are still considered to have an entry tear in the ascending aorta proximal to the innominate, but now with a subscript designating the distal extent of the tear. For instance, an A9 dissection would have its distal tear extending below the renal arteries but stopping above the iliac bifurcation. Type B dissections now include the arch distal to the innominate and have 2 subscripts, one for the proximal and one for the distal extent of the dissection. The proposed classification scheme can also be used to describe the locations of intramural hematomas and penetrating aortic ulcers. Finally, the authors also propose a classification scheme for high-risk and complicated aortic dissections, as well as the chronicity of aortic dissections. So, Dr. Gloviczki, what were some of the goals that the authors were trying to accomplish with this document?
Well, this is a long-awaited document, and the authors achieved the goals that they set for them in a way that this is a multi-specialty document. It is very important that the document brings together opinions of experts in the Society for Vascular Surgery and the Society for Thoracic Surgeons. Second, it is very important to define accurate reporting of a disease and of its treatment. Obviously, we all look for better guidelines how to manage these patients, but without accurate data and updated reporting standards, this is frequently difficult or actually not even possible. So the document has multiple important sections that's very important to study. It defines aortic dissection, intramural hematoma, and penetrating ulcers. But more importantly, it defines very important subgroups that affect outcome. So when different papers talk about outcome of patients who undergo treatment for aortic dissections, they frequently mix low risk with high risk patients, complicated with uncomplicated dissections. And there has been also a disagreement about the chronicity of the disease, the time from onset of symptoms to the time of the intervention. So it is actually very important that in addition to defining or to offer a new definition to the Stanford A and Stanford B classes, which before this document excluded really the aortic arch, it provides a lot of important information about accurate reporting of evaluation and outcome of aortic dissections.
Thank you very much for that. And so it sounds like this system is meant both for clinical use and reporting and research. Is that correct?
Well, interesting enough, I don't really think it's going to make the Stanford or DeBakey classification disappear from our clinical practice. And the authors actually make a statement in the document that with the multiple segments of the aorta that is involved and with defining more clearly the anatomy of the dissections, the primary purpose of this document was to use this detailed classification for reporting accuracy. So I believe that it may very well take over the classification of the dissections entirely, but I believe that we are still going to use the type A and type B terminology and maybe even the Becky classification. But I think all of us will now remember that type B dissection includes not only the descending thoracic aorta, but also the aortic arch.
Well, thank you very much for that. And I encourage the listeners to take a look at this classification scheme as it may get more popular and as it will help improve the accuracy of reporting. Our next paper is titled Incidence, Natural Course, and Outcome of Type 2 Endoleaks in Infrarenal Endovascular Aneurysm Repair based on the Engage Registry data by Dr. Dijkstra and colleagues. This is the CME paper of the month, so for more information, please visit the JVS website. This was an analysis of EVAR patients in the Engage database, which is a prospectively collected, non-randomized, worldwide database with 79 participating centers. Among 1,090 patients with follow-up data on endoleaks, 197, or 15.6%, had isolated type 2 endoleaks. 37% of these were detected within 30 days, and an additional 37% were detected within 1 year. Not surprisingly, patients with type 2 endoleaks had higher incidence of aneurysm growth and required more secondary procedures than those without endoleaks. Interestingly, though, overall survival was actually higher in the type 2 endoleak group, 77 versus 67% at 5 years. 22 patients with type 2 endoleaks also went on to develop new, late type 1 endoleaks, 10 of which were type 1A and 12 of which were type 1B. These patients were more likely to have short neck aneurysms at baseline and required more secondary endovascular procedures, of which 75% were successful. And unfortunately, of these patients, 18.2% developed aneurysm rupture. So, Dr. Gloviczki, this is a very informative paper with a lot of information. What does this add to what we already know about the subject? And are any of the numbers surprising to you?
Well, this is good information coming from a large database and a long follow-up. Some of the data are surprises, some of them are not. We know that type 2 endoleaks develop, and the incidence that was found in this paper was 15.6%. It confirmed that not all endoleaks are immediately detectable, or not all of them occur immediately after the procedure. Only about 1/3 of them occurred within the procedure and another third within 1 year. There are late appearing type 2 endoleaks as well that were not present previously. The study also confirmed that if the patient has a type 2 endoleak, a subgroup of these will grow the aneurysm, and some of them actually need secondary intervention and have more side effects, specifically rupture. What is interesting in this study is that they found that there was a small group of patients, 11%, that developed late type 1A or type 1B endoleak, and this group of patients required more secondary intervention and had more aneurysm-related morbidity than those type 2 endoleak patients who did not have associated type 1 endoleak.
So with regards to that 11% of patients, are you surprised that the number is this high? And is there anything we can do to prevent this, or is this just something that we should be aware of and we need to look for this carefully when we're doing active surveillance?
Well, the study really couldn't come up with definite risk factors of which patients develop type 1A or type 1B endoleak. It appears that patients who have large aneurysm sac are at higher risk. It also appears that maybe patients who have a short neck have a higher risk to develop an associated type 1 leak. It is also possible that these patients who develop type 1 endoleak actually never had a type 2 endoleaks. They actually were intermittent type 1 leaks. So I think, if anything, my take-home message from this is that beware those type 2 endoleaks that appear late. And certainly if this is in patients who have large aneurysm or a short neck, then be ready for a secondary intervention or let the patient know that there is an increased risk of potential type 1 leak and associated morbidity.
So one last question. I thought it was very interesting that patients with type 2 endoleaks had higher overall survival. Why do you think that might be? Is it just because we're surveilling them more closely, or is there something else going on?
Well, it tells you that this is a retrospective registry study. And surprisingly, we find data that we have difficulty to explain. I think it may make sense that these are the patients that we follow more meticulously, so maybe we are treating the patients better and we pay attention to associated comorbidities. It also tells you that we don't really know in many of these patients the cause of death. We really don't know sometimes if the patient died, whether it was an aneurysm-related mortality or a mortality due to another significant comorbidity.
Okay, great. Thank you. Our next paper is titled Critical Analysis and Limitations of Resting Ankle-Brachial Index in the Diagnosis of Symptomatic Peripheral Arterial Disease Patients and the Role of Diabetes Mellitus and Chronic Kidney Disease by Dr. Abu Rama and colleagues. This is a single-center retrospective analysis of patients with symptomatic PAD undergoing testing with resting ABI with or without toe brachial index to attempt to determine the diagnostic accuracy of these tests for detecting a greater than 50% arterial lesions. ABIs were deemed abnormal below a value of 0.9, inconclusive above a value of 1.3, and non-compressible if occlusion did not occur at a pressure of 250 millimeters of mercury or higher. Among all comers, the sensitivity of ABI was only 57%, with an overall accuracy of 74%. For diabetic patients and patients with CKD, the sensitivity was even lower at 51 and 43% respectively. For patients with both of these, the sensitivity was 36%. Similarly, the overall accuracy in diabetic CKD patients, or both, was 66, 67, and 59% respectively. Sensitivities remained poor when excluding patients with inconclusive ABIs. There was some improvement in sensitivity when toe brachial indices were used. However, patients who had this study performed were significantly more likely to have limb-threatening ischemia, which may influence those results. So, Dr. Gloviczki, what should we take away from this paper? I mean, we're always taught in medical school and in residency that ABI is an important number to think about. Is this paper telling us a different message?
Well, you are right, Jacob. This is a little bit of a sobering paper telling us that 43% of symptomatic patients with PAD had normal or inconclusive resting ankle-brachial indices. It certainly identified again the high-risk groups, and these are diabetics and those with chronic kidney disease. We know that they have a significant problem of non-invasive evaluation because of the associated Mönckeberg sclerosis, the calcified non-compressible vessels. I think it is important that our readers know about the global guidelines and the currently recommended non-invasive evaluation of patients with PAD and specifically with limb-threatening chronic limb ischemia. That includes ankle-brachial index and toe pressure measurements as well, because it was obvious from this paper that adding toe pressures and toe brachial index increases the sensitivity and overall accuracy of the non-invasive evaluation of these patients. So my take-home message is that we need, certainly in patients with diabetes and acute kidney disease, additional non-invasive evaluation in addition to ankle-brachial index, resting ankle-brachial index, and obviously exercise ankle-brachial index is something that should help the sensitivity, but many of these patients are sedentary and they have severe limb ischemia that prevents exercise, but toe pressure measurements, or in many institutions, other non-invasive evaluation techniques are available. Here at Mayo Clinic, we have used for many, many years now transcutaneous oximetry measurements in these patients that we found as a useful tool in patients who have diabetes or chronic kidney disease. The other techniques that are available in some institutions like volume recording or laser flowmetry, other non-invasive techniques that potentially could be considered.
So one of the things I also noticed in this paper, while the sensitivities reported were not good, the specificities in most of the subgroups was actually greater than 85%. So if an ABI is positive, can we still use that as a good indicator of an underlying problem?
Well, yes, the numbers look better, and it is a reasonably good indicator. My recommendation is that in any patients where you suspect abnormally high values or normal values, but the patient is symptomatic, and that your clinical suspicion is that that patient has peripheral arterial disease, further non-invasive and minimally invasive imaging techniques should be used. So high index of suspicion in symptomatic patients who have normal or inconclusive resting ankle-brachial index is the message of this paper.
One last thing, if we do perform more advanced imaging on all patients, such as duplex or PVRs, are we potentially putting ourselves at risk of overdiagnosing lesions that don't need to be treated?
Well, I think that's where the clinical judgment is very important. In a patient who is symptomatic, who has advanced symptoms of rest pain, tissue loss, or gangrene, I think imaging is almost mandatory. So I would say clinical experience and clinical judgment will help you to avoid overdiagnosing those lesions that don't need to be treated.
Thank you very much. Our next article is titled Long-Term Freedom from Aneurysm-Related Mortality Remains Favorable After Endovascular Abdominal Aortic Aneurysm Repair in a 15-Year Multicenter Registry. And this is by our own Dr. Nicole Rich and colleagues. This is a retrospective review of patients undergoing EVAR at 17 Kaiser Permanente Northern California centers from 2000 to 2010. Data on these patients was actually already published in 2013, and this paper provides a more long-term follow-up, so we will put a link to the original manuscript in our show notes. The current study extends the follow-up for these patients to a maximum of 15 years, and patients were also sub-analyzed in early and late eras from 2000 to 2005 and from 2006 to 2010, respectively. Overall, unadjusted survival rates at 5, 10, and 15 years were 64.4%, 34.6%, and 11.8%, respectively. Crude aneurysm-related mortality was low at 3.6%, or 0.66 deaths per 100 person years. Significant predictors of aneurysm-related mortality included female sex, age 80 to 89 years at the initial EVAR, aneurysm size greater than 5.5 centimeters, urgent EVAR, and any major reintervention. When sub-analyzing the early and late groups, freedom from aneurysm-related mortality was not significantly different. However, unadjusted 5-year survival was higher in the late group at 66.8% versus 59.8%. However, there were differences in the baseline characteristics as reported that may account for this survival rate. So, Dr. Gloviczki, what do these data add to what we already know from the many randomized trials that have looked at EVAR versus open aneurysm repair as far as what the durability of EVAR is in the long term?
This is a little bit different from, obviously, the randomized studies. It is a large population of patients who underwent endovascular repair. The procedures were performed more recently than most of the large randomized studies. This was a study between 2000 and 2010, so it is not only a more recent experience, but different devices. I would say better, different generation devices were used than in many of the previous studies, specifically in the UK EVAR randomized control trial that has similar follow-up. The follow-up is very important in this study. They went up to 15 years after surgery. The limitations, of course, are that this is, again, a retrospective study, that the information on the anatomy of the aneurysm was not always available, and that a multitude of devices were used. But what is the take-home message? The take-home message is that in a large number of patients, the procedure can be performed with a low aneurysm-related late mortality. It was 3.6%, a median follow-up of 5.5 years. And that the delayed rupture rate appears to be lower than previously reported in this population of all comers. It was 1.3%. And the major intervention rate was 10.3%.
So one of the things the authors were trying to show was a difference between early and late eras in terms of aneurysm-related mortality. However, those were not significantly different between the two groups. Were you surprised by this at all, and did you expect to see a difference?
Well, I don't know, again, what type of devices were used. I think the information is really not enough that's given in this paper to really be too excited that the more recent operated patients didn't have a better outcome. We found a better outcome, but we went back in our experience a little bit earlier, and clearly there was a huge difference between the first and second generation devices than maybe between the second, third, or even fourth generation devices. So I would say that this group of patients that were operated between 2000 and 2010 already had investigators who were beyond the learning curves, and maybe that's why we didn't see the difference.
Our last article is titled, The Incidence and Risk Factors of Stent Fracture in Patients Treated for Proximal Common Carotid Artery Stenosis by Dr. Vertes and colleagues. This is a single-center analysis of patients undergoing stenting for significant stenosis of the proximal third of the common carotid artery from 2006 through 2016 that attempted to characterize stent fractures for patients undergoing this procedure and correlate these to in-stent restenoses. Balloon expandable or self-expanding stents were placed through a transfemoral approach by 3 different interventional radiologists, with the ultimate decision of type of stent and primary versus direct stenting left to the discretion of the radiologist. Of note, cerebral protection devices were only used in patients with tandem carotid lesions. Among 70 patients who were included, only 1 patient had a periprocedural stroke. 38.6% of patients developed stent fractures over a median follow-up of 75 months, with most being either type 1 or type 2 fractures, and the authors describe what those are in the paper. However, there was no significant association between stent fractures and in-stent restenosis or reintervention. And of note, the overall rate of in-stent restenosis was 11.4% of the cohort. So, Dr. Gloviczki, we hear a lot about internal carotid stenosis and the associated stroke risk, but for some of our junior residents and medical students who are listening, can you briefly talk about common carotid stenosis and its management and how that may be different from the same problem in the internal carotid artery?
Well, this is an interesting paper that kind of also reassures us that not all stent fractures are evils, and not all of them require secondary interventions or is going to change the outcome. Now, this paper comes from the Semmelweis University that you may know. Jacob is my alma mater, so I trained at this institution, and I know what a fantastic job they do in the field of carotid artery management, both in endovascular treatment and open surgical treatment. They treat a large number of patients. So the experience is significant. These were patients with transfemoral carotid artery stents. They used a variety of stents, but they had good follow-up that averaged 75.5 months. And maybe a little bit of a drawback was that they used different type of stents, but they also made it clear that some lesions are better treated with self-expanding stents, and these are the softer lesions. The longer lesions On the other hand, the orifice lesions between the left common carotid artery and the aorta, or between the right common carotid artery and the innominate artery, firm calcified stenosis, and these lesions need balloon expandable stents. The stent fracture rate was somewhat high, 39% during the 76-month follow-up. That's kind of worrisome. On the other hand, it was reassuring to see that the primary patency rate between the fractured stent group and the non-fractured stent group showed no significant difference. There was no difference in patency between the groups. There was no difference even in reinterventions. When they looked at the cause or the factors that were associated with the stent fracture, vessel calcification was the only predictor of stent fracture with an odd ratio of 13.2. So again, this is a difficult group of patients. We have seen in the literature lately that it is not very advisable to do retrograde carotid stenting combined with bifurcation endarterectomy. These procedures were the transfemoral stented patients. It certainly needs very careful patient selection. Who are the patients who are suitable for this type of stenting? So I think it is important that these procedures are performed by highly experienced operators and with a scrutiny on indication of the procedure.
So you mentioned that the authors didn't see an association between a stent fracture and in-stent restenosis. And obviously the concern with a stent fracture would be the recurrence of in-stent restenosis. Do you think that there's a possibility that because the numbers were pretty low in this paper that there may be underpowering there, or should we be reassured by these findings?
Again, this is a retrospective study, and the number of patients in different subgroups and certainly the different type of stents that bothered me a little bit, that the overall, I think a larger number of homogeneous group outcomes would be needed to really make meaningful decisions on this.
One last question. You also mentioned calcification had an odds ratio of 13.2 for predicting a stent fracture. Do you think that people should consider calcification as a contraindication to stent placement, or is this just something that we should be aware of and then we'll deal with the consequences if a stent fracture does occur?
Well, I think, again, we have to read between the lines. It looks like the calcification in this study was defined by fluoroscopy and not in all patients by preoperative CT scans. So it is also important to see how do we define calcification. But at least these data support the fact that even if because of the higher calcification there is stent fracture, it appears that stent fracture does not significantly affect patency or reinterventions.
Dr. Gloviczki, thank you very much for your insight. We look forward to speaking to you again soon.
Thank you very much, Jacob, and we are looking forward to continue these conversations with you and your colleagues in the future for both the Journal of Vascular Surgery and the Journal of Vascular Surgery, Venous and Lymphatic Disorders.